Test 1 1, test 1 1.
to address the committee? Do we have any today?
We don't have any.
Okay. I don't believe we have any today, so we will just continue moving on. We will move to the approval of the minutes from the last Quality and Patient Safety Committee, which was only in June. We got a little off.
Yes, the boot is not related to JPS. Thank you, Dr. Holland, members of the committee. It's an honor to always present quality and share some of the extraordinary work we do at JPS. For this month, I wanted to share another perspective from one of our patients and their family. The story I bring to you is from the voice of a very young daughter who is seen her very young mother for many years suffer from a very unique and rare condition that results in her mother not being able to breathe and develop refractory ascites. The patient has had to come to JPS almost every week, and our team at JPS came up with a very creative solution to make sure her care can happen at home. So this is from the daughter's voice. It's been a very hard past year. It's been a very hard couple of years, especially the last year. It became very hard to see my mom starting to develop fluid in her stomach. She was in the hospital every week to have her stomach drained. It was very exhausting, not just for her, but for my father and I. My dad is and me are her only family here, and it's getting very hard for all three of us. She was getting her stomach drained once a week, and so I felt like that was still not enough. We would come home and she would start complaining right away that she felt uncomfortable and she could not breathe. I think that the fluid was exerting so much pressure that there was very little room already because of her lung condition. We were doing everything we could at home. From our diet and the meds that she was taking, it was still not enough. We are so happy with the JPS team who placed the Plurix catheter, and with that assistance, been able to take care of her at home. It's been such a nice feeling to just be home and do the smallest, simplest things of having a routine. It's been a great thing for my mother, for my dad, and I. We are also so thankful to just be able to sleep in our own beds. It's definitely having an impact on my mom's mental health, but also on my dad's and mine. It's just being at the hospital for days on, every single week is exhausting. Not able to eat a home-cooked meal, just be in your own bed was very, very draining. We are so thankful to JPS for all that they have done for us, and we are very blessed. So I want to share that story from perspective from a young daughter.
Thank you for that. I think that's a great reminder of why we're here and why we're doing what we're doing today. So thank you. All right. And then another positive aspect of this meeting is we're going to talk about the Golden Mitt Award winners. This is given in honor of patient safety. And so, Dr. Carla Putty, would you like to announce the winners?
Yes, Dr. Holland. We have 3 Golden Mitt Awards for this month. We have May, June, and July. For the month of May, it is my great pleasure to announce the Dr. Charles E. Weber Jr. Golden Mitt Award to P5 Surgery, Trauma, and PCU Unit. They were nominated by our Clinical Risk and Accreditation team. In February 2023, the P5 team implemented a new process to monitor how they monitor the heparin drip changes. In their new process, they have either a team leader or a heparin champion or another leader who serves as a dual sign-off when any rate change happens to heparin. And as we know, heparin is one of those high-risk medications that we have to monitor very carefully in the hospital. And since that new process was implemented, the P5 team has not had a single error in heparin drip rate change. So for that, and for many other things that they do, they have been nominated and are awarded the Dr. Charles E. Weber Jr. Mitt Award for May 2023. Memorial Day picture. Okay, our next award winners are for the month of June 2023. It is my pleasure again to announce the June 2023 Dr. Charles E. Weber Jr. Golden Mid Award to our behavioral health technologists. They were again nominated by the Clinical Risk and Accreditation team. Our behavioral health technicians observe every patient who needs to be monitored in seclusion or restraints, and they do these observations every 15 minutes. They have recently integrated a new system whereby documentation of the observations that they do are actually done on an iPad, and therefore they can be very efficacious in documenting all the many things they have to do in observing patients in seclusion or restraints. And they're from May 1st to May 31st, JPS is above average in all areas of compliance as it relates to that monitoring tool. And for that, the clinical risk team has nominated, and we are glad to award the June 2023 Charles E. Weber Jr. Golden Mid Award to our behavioral health techs. Our next award winners for July 2023 are our renal dialysis team. It's with great pleasure I want to announce that they have been nominated and are recipients for the 2023 Charles E. Weber Jr. Golden Mid Award. I had the great pleasure of actually rounding with them, and they were nominated by our infection prevention team for some of these reasons. Our dialysis team is highly dedicated in serving our patients and have excellent quality practices as it relates to all aspects of dialysis and CLABC care. I can attest, I tested, and they won every single question. They were really, really good. They also set aside a lot of time to educate and collaborate with patients and infection prevention to make sure that their IP practices are top-notch. For that, the infection prevention team has nominated, and the July 2023 Charles E. Weber Jr. Award goes to our renal dialysis team.
Thank you, Dr. Carla Putty, and thank you to our teams and our Golden Award winners, what I heard and what Dr. Carla Putty was just how proactive these team members are in patient safety, and that is just makes me feel so proud of this team and all the hard work they're doing. So again, just want to congratulate P5 Behavioral Health and Renal Dialysis one more time for their wins these months. All right. We are now going to start talking about clinical quality. Dr. Carla Putty is going to discuss what we're working on currently.
Thank you, Dr. Holland. Since our last meeting was just 6 weeks ago, and we talked in depth about a lot of quality metrics, for the month of August 2023, I wanted to focus our clinical quality measures on 5 specific quality measures. The first one being maternal health, second, restraint use, readmissions, ease of appointments, and then diabetes care. The reasons we selected these measures are because of their timeliness in what's happening in improving patient care, the opportunities and challenges we have to optimize maternal health in the state of Texas and in the country, the ever-growing challenge with readmissions, and then we wanted to include 2 measures that are not inpatient-focused, but are actually focused on outpatients, and try to connect the work that we are doing to what patients are actually feeling and telling back to us. So with that, that's the context to our meeting, and we'll start with maternal. Wrong button. Maternal morbidity, for those of you who don't know, is defined as any health condition that is attributed to or complicating pregnancy and childbirth that has a negative impact on women's well-being or functioning. This is a WHO definition that's used worldwide. So it's any condition, and it's still 12 months after pregnancy. JPS has done a lot of work in the space of maternal morbidity. One of the things that I learned early in the journey is JPS is one of 3 hospitals in Fort Worth that has actually received level 4 status when it comes to levels of maternal care. There are 4 levels of care, 4th being the highest level provided by the state of Texas, and JPS has the 4th level, which essentially says that after a rigorous process, independent evaluators have felt that our standard of care and the services we provide is of the highest standard. So you have to meet rigorous standards. So with that context, I want to share some information with you on maternal morbidity. The risk factors for maternal morbidity are essentially a lot to do with prenatal care. Adverse social determinants of health is a significant risk factor, and then actually having access to high-quality prenatal and postpartum services. Severe maternal mortality is actually something that actually threatens mothers' lives, and 3 major reasons for that are hypertensive diseases, postpartum hemorrhage, and sepsis. So when we look at maternal morbidity, a lot of risk factors are pre-hospital. They happen before the hospital. A lot of severe maternal morbidity is the impact of prenatal care that comes into the hospital. And JPS does a lot of work to optimize the care of patients who come in with severe risk factors for having bad outcomes, and then takes really good care of them. The next slide will speak specifically to hypertension. On this slide, you will see 3 measures. Are we giving medicines on a timely basis? Are we treating patients with magnesium appropriately? And then if patients have hypertension, how are we getting them scheduled back into the outpatient world within a timely period? Our target on all 3 metrics is 90%. This work started about 4 months ago, and I'm happy to say that within the first 4 months of this work, we're almost at 83%. This will be ongoing work essentially to make sure that we are on top and get 90% compliance in diagnosing and treating antihypertension, using magnesium appropriately, and then making sure mothers postpartum have an appointment 7 to 10 days after delivery to be seen for hypertension care. The next slide actually talks about postpartum hemorrhage. This is a condition when mothers suffer more than 500 ml blood loss after delivery. And there's a lot of work that has happened in the space of postpartum hemorrhage. And these slides are not updated because I got this information on Friday. In 2019, the rate of postpartum hemorrhage at JPS was 20.9%. In 2022, it was 11.3, and it's now down to 10%. So the slide is not accurate, the updated data is. So we have seen a significant decrease in our postpartum hemorrhage, and we have done so by actually making sure we know which of our mothers are at the highest risk for postpartum hemorrhage, and how do we reassess them very often to make sure that if there is any way we can intervene early, that we do. How do we get ready for these high-risk mothers with blood and that's crossed and type matched so we can resuscitate quickly? And then revising the protocol for maternal hemorrhage. In addition to that, a team has done a lot of work to improve sepsis, which is a risk factor for postpartum hemorrhage. You will see in the next slide. So we've done a lot of work. National average on this is 9%. And for our current state, again, the slide is wrong, it's 10%. And we've seen a significant decrease year over year in making sure that our postpartum rates are improving. And I feel very confident we'll get to the national average pretty soon. Again, please remember, this care is being provided in the context of patients coming with significant risk factors in the prenatal world. So we're just doing this in the hospitalization world. The next slide is actually about sepsis. Detecting sepsis is key. Recognizing and treating it is everything. And when we look at our sepsis bundle compliance, the target is to be at 66, and we are at 68. For those of us who are wondering why is a target of 66 good, sepsis has been one of the most difficult diseases to actually measure, and you don't want to get 100% on the sepsis bundle, because one of the bundle measures requires, as Dr. Huggins knows very well, is to give a certain amount of crystalloid, and you do not want to give all that amount of crystalloid in clinical, if not clinically indicated. So our target for this measure is 66%. In our current state, we are 68%. The team has done a phenomenal job in making sure they have the right sepsis bundles. They activate the sepsis team when it happens. They have an EPIC access order that they're working on. And second, they have done a lot of quality improvement work, and they have optimized vaginal exams to decrease the risk of chorioamnionitis, which can happen when there's a lot of exams done that's not required. So the team has done a lot of good work there. So we're seeing good work with sepsis. Any question on, because I'm going to move away from maternal morbidity.
I have one question on the hypertension aspect. The action plan is antihypertensive medication ordered timely, and the progress is about 87% on that. What is the biggest delay in that care? Just that the patients are not being triaged, or is it that it's recognized they have high blood pressure, but there's time to get them to medication? That's the delay.
I think the definition of that, if I'm not wrong, has been defined as, order to getting the drug within 30 minutes. I think there's a little delay in that, so we're trying to optimize that process. Again, these patients take their medications at home too, so we have to make sure that we don't double dose them. So there's some lag that happens. The doctor does the order, the nurse gets the order, and the drug's given. So 87.4% looks like that we're not doing it, but from our percent, the target is 90% because we have so many variables to look into. So the challenge we see sometimes in healthcare is when patients are not able to tell us the history, or we don't know the med list, and we're trying to check through pharmacy the med. So that can be another challenge. But I think the team has done wonderfully in trying to get to those numbers.
Yeah, I actually had a question as well. If memory serves, we did develop an order set for maternal antihypertensives that gave people a cascading order set in case the patient doesn't respond. Is that correct?
Yeah.
That is correct. Okay. And I'm wondering where the target of greater than 90% came from.
That was set up internally by the team. That was set up by the maternal, the chair and the dad partner. I have not looked at national data to see if that is the data, but that's a targeting point that they wanted to get at 90%. As we benchmark these to our targets, one of the things we will do is build the rigor around what our national targets are and what our state targets are. And that's a very good question, Dr. Miller, but we are not there at that point to actually set a national target for this.
And just to be clear, these are women who become hypertensive upon admission?
I think these are
We
patients.
triage when they present
yeah.
to us in the inpatient. This is not an outpatient measure. This is
No,
an
this is inpatient.
measure.
This is pure
Thank
inpatient
you.
measure.
Thank you.
Question on that. I know this is inpatient, but do we kind of look at where they were when they was being treated in the outpatient? Are they controlled there? So, and when they come in, they are not controlled. Is there, how do you look at that? That's what I'm trying to say.
So when I last spoke with Dr. Sangha, what she said is that a large number of patients who come to us get some amount of prenatal care. It's not considered all kind of prenatal care. And the quality of blood pressure control during the prenatal period sometimes is an opportunity because on, where the mother is getting her care, where are they getting the refills from and stuff like that. So so it's both, to your point. It's through the prenatal period, and sometimes we actually detect mother to have severe hypertension at the time they show up to the door. So we get both sides.
Another thing, as we are looking at that, let's try to identify the ones that are getting prenatal care to make sure that we are on target there versus the ones that have not got prenatal care.
Happy to separate out the two
Okay,
populations.
thank you.
Thank you for those great questions.
And I'm going to give kudos again to our blood management team because the tremendous drop in maternal morbidity related to postpartum hemorrhage was due to a very multidisciplinary collaborative approach to developing a very strong protocol and order set around maternal hemorrhage. And that was actually fabulous work, and I'm happy to see it is still showing positive benefit.
Yeah, it's a great program. Great point, Dr. Miles. Moving away from maternal mortality, this is a very complex rate, so I'm going to say it out one time. It's nulliparous full-term singleton vertex presentation, that is single mothers at term who are presenting with single baby presenting by vertex. What is the proportion of those pregnant patients and having a C-section? And it's a very complex metrics, but our state average is 27%. We are at 29.1%. We are working in a QI process improvement way of trying to decrease those rates. The clinicians always have to balance the need between doing a C-section and then also optimizing outcomes for the babies. So it's not about one rate. You also have to make sure the child is okay. So when we look at this measure, we look at it from both sides. The process steps are being worked at to identify mothers who need higher dose of Pitocin to make sure that they are optimized to actually have optimal uterine contractions. They're also optimizing vaginal cytotech as for induction. The teams have also started re-educating and reusing a standard score that predicts, success of induction, the Bishop's score. There's a lot of work in trying to document and make sure that we know up front which patients might succeed or not succeed with Bishop's score. So therefore, we are doing these C-sections in the planned and not emergent way. And then finally, I think the most important thing is every time the team has to do a C-section on a normal, on a nulliparous term singleton vertex presentation, they go back, look at the case, try to identify what they could have learned and done differently from each case, so they have a process of continuous learning within the environment to make sure that they can improve this measure. So while we are not at national average or state average, I feel fairly comfortable that there's a lot of work being done to improve this metric, especially when we have to make sure that fetal outcomes are good. Those were the two metrics that I wanted to talk to you about in the maternal health space. The next one is the use of restraints and seclusion, and this is only for behavioral health. This is not for ED, this is not for inpatient, this is only for behavioral health. And the reason I wanted to bring this to the board is, as we have seen the challenges with finding people, technology, and making sure our patients who require either seclusion or restraint use for their own protection, we have to have the most rigor in making sure they are being done in a safe place. And then we have done a lot of investments in this, and the technology we brought in, and thanks for the board for supporting that, is Observe Smart. This is a technology brought in, and we have it that we're using right now in behavioral health, and we recognize our behavioral health techs for actually exceeding the standards for that tool in making sure that every 15 minutes when there's somebody in isolation or in seclusion, they are looked at, eyes are laid upon, and they have a complicated checklist that they have to make sure that they're doing it every single time. And then that documentation connects directly to Epic, which makes documentation less for our techs, and therefore it is a significant employee satisfier to have this technology. So we have right now investment in this. It's nationally important to make sure we provide safe care, and we also have employee satisfaction with the tool that we have. So I wanted to make sure we bring this to the board to say we're doing well. On our seclusion targets, we are at 0.23, which is better than national target. Physical restraint, we're at 0.28, slightly above national target, but I don't think that to be a significant opportunity for improvement. Restraints are significant. They are always top of mind for Joint Commission, for CMS, for all regulatory purposes, and I thought it's important for the board to know that. Questions?
You mentioned that these numbers are specific to behavioral health. Is it similar techniques that we use restraints in other areas of the hospital, like inpatient?
Yeah, inpatient in ED, I'm starting to discover, I think we use the rovers right now, and I'm trying to pull the data to see. We have an auditing process where we go and audit these areas on restraint, so our clinical risk team also does that as part of their daily standard work, and we are good at that. The reason I brought behavioral specifically is because of the investment we made in the new technology and the way it's helping our caregivers feel good. They don't have to reduplicate, so I wanted to showcase that.
Because if it's successful, then maybe that technology could help the other areas.
Yeah, absolutely, Dr. Holland. We also want to make sure that the areas of the hospital actually meets the use case. I do not want to assume for my partner in crime, my CNO there, because his use case for ED has to match the use case for behavioral health. So once we have success here, we can have the teams to connect together and see if it actually works, because the work environment might be different in behavioral health compared to here, so the same tool might not work. Next, reducing 30-day readmissions. I have lovingly called 30-day readmissions a 10-headed hydra. It's been my life's work to reduce readmissions for Peace Health and for JPS. It's one of the most complicated metrics because it captures the entire spectrum of healthcare. Our target was to reduce all-cause readmissions to be below 10.4%. That was our AIP goal. Our current state is 11.33. We are not at target. Our team did a lot of work in trying to understand exactly where we are going with 30-day readmissions, and what we found during that journey is that there is a small but sizable population of patients who get readmitted to us more than 4 times a year. What we found is those patients contribute to 30% of readmissions. So it's a very small group of patients who keep coming again and again to JPS, get readmitted, and they disproportionately affect our readmission score. So what we are trying to do, and it's a well-recognized national program called the multi-visit patient, and it's also called the most valuable patient because they use the most valuable resources, that we are going to be designing a program around them. We have identified 139 patients, and the aim is that as soon as we have that patient in the hospital, a group of multidisciplinary individuals, case management, social work, physicians, nurses, come together and create more comprehensive care plans that are successful in the outpatient world. One of the challenges with this patient population is they have come again and again to us, and we have told them again the same. So this work has to be new. The questions have to be new, and we have to ask these from a patient's perspective and trying to get to that answer as to what is bringing them in. So it's going to be a lot of work for a very small patient population. We have the team designed, we have the data, we have started the work, and we'll be measuring and progression of that work over time. Yes, ma'am.
Can I ask a question? When they're being readmitted, is it for the same complaint that they came in the previous time?
Sometimes, and sometimes not. Sometimes it can be related, but not. It can be so when you have somebody with new complaint, yeah.
Okay. I was just wondering if sometime they come in with a complaint, we treat that then, but that's not going to go away. So they go home and they come right back because we didn't really try to find out to deal with the underlying issue. So that was what I was asking.
If I may indulge, we also look at patients who return within 7 days, within 14 days, within 30 days. And as we look at the spread of these patients, we're going to look at that spread to figure out, are we doing something differently? We want to make sure that this patient population has an extraordinary amount of disease burden in addition to their socioeconomic disadvantages. So supporting them holistically and trying to help them come.
Let me ask one other question. This is readmission at our hospital. What if we dismiss them and they go into Harris 7 days later? How will we know that?
That's actually a very good question. I have to look at the data for JPS right now. It's all cause readmissions, all hospitals. So if it's CMS is the payer, they know if you have gotten admitted JPS and readmission, so they'll count it as ours. It's not for all payers, but CMS knows that data.
I think we would know if JPS patient, one of our connection patients.
Yes, we will know
that. That would be the other one I'm
Yeah.
looking at. Okay.
The next slide actually tries to explain why we are at 11.33. So for those of you who don't know, sometime in February 2022, we discovered that we had a disproportionate amount of observation patients compared to inpatients. And there was a lot of work done to right size to find the right balance between observation to inpatients. It's a category that we have to place patients in. So anybody who requires higher level of care, meets a certain threshold, gets to inpatient. If they're lower level of care but still need to be within the four walls of the hospital, they're called observation. And only inpatients count towards readmissions. Outpatients do not. So we did a lot of work to right size that ratio. And when you right size the ratio, what we did is we decreased the observation, and the high risk observation patients went into the inpatients. As a result, what happens is the acuity, the readmissions is calculated as observed over expected. So CMS looks at your numbers and say, based on the number of admissions you've had, based on the number of amount of complexity you have a certain number of people we expect to get readmitted. If you get more than that, you get dinged. If you get less than that, you get rewarded. So when you change your ratio and add more patients into inpatient with lower acuity, it starts to look like you have more patients readmitting for a lower acuity. Nothing has changed in the world. You've just changed the status. So when you look at the graph, the green line at the bottom, which I should have made it a brighter green line, actually shows you what readmissions would have been if we had done nothing. We had to do it. That was the right reason to doing it. But this is what we try to do our best, is to calculate and give you an estimate of what the world would have looked like from a readmissions perspective had we not changed inpatient to observation. So my hope is that we will take the MVP plan, bring it, mature it, make sure we have that, and then have a staged, progressive, thoughtful approach to every aspect of readmissions. It's a multi-year journey, and it takes investment. So we're starting with the multi-visit patients, and we'll go from there.
Ask on the observation patients that are admitted to observation, they're dismissed. What happens if they come back and it's admitted to observation within?
They are not counted in the CMS all-cause 30-day readmissions.
So we could have a high turnover in observation, but okay. Okay. Well, that would be a way to hide it. You're just not hiding it, but you just admit it, and we're just going to keep you in observation. Next time you come in, we put you in observation.
No.
Okay, thank you, Colin. I'll back off of it.
No. Yeah.
Yeah, change there. It's like, why did you do that now, Colin?
And CMS is very aware of how that happens.
All right, okay, all right.
All right. Moving on from inpatient to outpatient, I wanted to share with you some work that has happened with ease of scheduling appointments. Our target is something we're still determining on that, but in 2021, our target time from contact hold time was 48 minutes. In 2022, that decreased to 11, and now it's 4.5 minutes. So we've decreased from 48 minutes to 4 minutes within 2 years, and that goes a lot of work that has gone into mainly infrastructure, making sure we have the right, all the work that we're going to do, the update the phone lines, optimizing of the staffing that's able to pick up the phones and answer, providers who are optimizing their schedules so we can get patients in, and then implementing decision trees into making sure that the schedulers, the people who pick up the phone, have a clear process on how they go through scheduling patients. And in a future state, it'd be wonderful if patients could schedule their own appointments in MyChart. There's open access. You can do it yourself. There's no wait. You can do this. And that's something we're working towards. It's one thing for me to tell you here that, we've decreased the ease of scheduling. It's another thing for me to tell you what our patients tell you, and that's what I wanted to share here. This is data from the patient's perspective, not from our perspective, but what patients are saying, what is their ease of scheduling appointments for overall medical practice, the graph on your left. When we started the work, even with 48 minutes, their patients said 65% said it was easy, and now it's gone up to 69. And same on the specialty practice, it's gone from 64 to 71. So we are doing the work to make it easier, and our patients are telling us it's actually easier. It's good to, sometimes we do all the work and they don't feel the effect of it. This was very nice to see that. I want to thank Dr. Duncan for actually telling me to put this slide in. So thank you, Dr. Duncan.
All right.
And the next one is something that's near and dear to my heart. Diabetes is the cause for many, many bad things with metabolic syndrome. And when patients come with diabetes, we want to make sure that they are prepared. It takes an extraordinary amount of lifestyle changes, exercise, food, and medication adherence to actually get diabetes under control. And a large part of this is educating patients. So this graph tells you that when patients come in, they're first established with us, what we do to decrease their A1C scores. Our target is to get to A1C of less than 7. Our current target for this year is 7.5. But I want to look at the middle table that tells you when patients come to us in 2022, their pre-class A1C was 8.9. And this year it was 9.6. And as part of structured education classes that are tailor-made for the individual needs of the patient, provided in a language that they actually understand, which includes a combination of food, lifestyle modifications, and making sure they understand the importance of taking medications, results in a significant decrease of A1C from where the baseline is. So it's remarkable to see where our patients start their journey, and after 4 classes, how we impact their life and their future life in decreasing their A1Cs to a target that's very, very close to 7. So while it's not at or under 7, again, diabetes care, we want to get them as close to normal as possible. Sometimes when you get them too close to normal, there are also consequences of that. So we try to make sure that we don't overshoot it. But that, from my perspective, even though it's red at 7.5, is a huge win.
I'm imagining some of this is also impacted by medication
Yes,
and
yes,
other
yeah.
like glucometers and things
Right.
like that. So well, I'd love for them to go down that much from education alone, 2 points in 23, right? I have a feeling that this is a multidisciplinary,
You're
not just
right.
the class.
Yeah, the class works with the primary care. I didn't elaborate on point 2. They actually work with the PCPs in making sure that, the primary care physicians know what education they're getting. And then as education alone will not do this. It's educating them to what they need to do with medications and food and nutrition. So
Are we just doing the classes when they come in, or are we able to, when you send out notices to them about their appointments, mine click up and says something about, I can do it right online. And it's just pretty easy to go through and do it there. So I don't know if we are doing that yet.
Yes, Dorothy, I was going to say, during COVID specifically, we launched virtual programs and classes. So our patients have opportunities to do both virtual and or in person as that The next iteration for diabetes care for education is for us to partner with our communication department to really put some videos that are links for those specific stages and for those kind of frequently asked questions, as well as demonstration from a video perspective that they could click on at any time, which would be maybe on our website. So that's really that's our next step in this journey.
I would ask that not just at any time, but triggers maybe a month before for their appointments, because this is just really, well, I couldn't do what I need to do until I looked at it. That was one of the reasons I had to look at it. But it was really simple and very educational, and just kind of a reminder of those things that you already know, but and it was easy. Didn't take up a lot of time, but it was there on my chart. It sent me a little message and said, you have an appointment, and there's a little education which you review as you do your online registration for your visit. So it's all tied together. So it was nice, and I was hoping that ours would do that. Okay?
I want to thank Joy for giving a much more informed answer to that question. I was going to write down, I don't know, I will find out. But thank you, Joy. Those were my slides for this month's quality presentation as it relates to clinical quality.
Okay. I have one more question before we leave that. On the, say, for the patients that's in certain, let's just say viral pits that has the diabetes, is there something we could do for that group that would be fun to kind of educate them, some education on their system, kind of what kind of food are you eating that we know you're going to eat, how can we make that healthier? Is there something we could do, kind of target, not a routine, but target something to occur in that area with all those patients that come, and a lot of them know each other anyway, so that's my question.
Yeah, Dorothy, and I think to your point, in our partnership with the Parent Area Food Bank, beyond just even the cooking classes, and we do this with Tchd medical students as well, is we offer in the Como Community Center that kitchen where we encourage our patients to come to that demonstration kitchen, and the dietitians in partnership with TCU, food from Parent Area Food Bank do that teaching. I think what we see there is opportunity for increasing the access and participation. And I go back to also video classes and things because not everybody can make it. So really trying to evaluate extended hours for that, different opportunities for them to engage. Our Tarrant Area Food Bank partners, we do the mobile red bus, but they're real excited about furthering that partnership, and then also as well as future partnerships for food deliveries and programs like that. We are trying to look at targeting certain days and stuff that we are doing stuff like
Back to school pack, well, you had to sign up, but in order for you to get it, you had to go through some education classes. We think that's a better way than they're going to get something, then you have to go through some things for us. So we're looking at target stuff maybe, and so I'll be glad to talk to you offline about that, but I think that would help because we do a lot of programs that we have them there. So instead of them coming in and we're giving up this, we do a off to college program where we help them with all of their college. Well, that's an education deal for us to say we do a lot of things. So we're thinking that if we target stuff when we are providing something that we get a good response for, then you need to hear our education. So that's what we're, okay?
I've been associated with programs, and I'm sorry if this is redundant for what's already going on in Viola Plitz and the other community clinics, but we do what's called a sugar rush, where everybody who it has an A1C above goal is called to join the sugar rush. And at that time, they do a point of care A1C, check their sugars, review meds, just really quick, things that don't require a physician or a provider to be there. And that is a good way to have a dietitian present and to have all those things and just have an outreach that just targets those patients who are at need. Yeah, so.
Great. Amazing discussion, sharing of ideas. Thank you.
All right. I think we're ready to move on to, we have one quality matter that is up for approval. Joy, if you don't mind joining us.
Go to community health outreach education to pharmacy operations. So here we go. Well, thank you so much. So today for your consideration is our policy for pharmacy operations. This policy is intended to establish requirements related to dispensing prescription medications to our patients and our employees. There were very minor modifications made to this policy, just specifically really related to defining on the P&T committee, just our in reference in accordance with our medical staff bylaws, so just basically kind of defining that who that is in agreement with that. And then also to make it easier for our team members, we linked our actual procedures that reference to each of the different sections within general information. So it was really just to make it a little bit easier for our team members to understand the policy, and then of course that definition change. So that is the modifications that I'm bringing forward for your consideration and approval.
Anybody have any questions about the policy? Can I have a motion to approve?
Move approval.
Second.
A second. All right. So we have approved the pharmacy operations. Dr. Carla Pudi, do we have anything in
Executive session.
in an executive session? No. Okay. All right. Let's skip that part. Is there anything further to discuss today? That's it. Okay. Well, then I make a motion to close this meeting.
All right.
Asking for a motion?
I'll motion it.
I have a motion. I have a second. Okay, so we will close this quality and patient safety meeting.
All right. Wow, that's the fastest one we've done.
Give me a high five on that.
Let me tell them.
You mean like